Thank you so much for that really kind introduction, Tamara. I'm going to take a moment to make sure that I'm sharing the right thing. That is something I've learned in teaching online. And hopefully everybody can see my slides. Okay, excellent. Yep. Perfect. And thank you everyone for logging into yet another Zoom meeting to attend this lecture. I know that there are just so many things on everybody's plates right now, and I'm really grateful that you chose to attend this event and add it onto your plate. I'm going to be honest, I fretted a lot about this talk because the Scholars Lecture is weighty and it's really important. And I've been in awe and learned so much from the folks that I've seen who've delivered it before me. So I decided that rather than try to fill metaphorical shoes that are just too big, I would approach this talk in my own way. I'm not a person who studies one thing, just like Tamara noted. My work cuts across clinical psychology, health psychology, public health, and medicine. So it didn't make sense for me to focus on one thing in this lecture either. And I hope you don't mind. In reflecting on my scholarship, I was drawn to a paper that I assign in maybe 60% of my classes. It's Dr. Lisa Bowleg's When Black plus Lesbian plus Woman Doesn't Equal Black Lesbian Woman, the Methodological Challenges of Qualitative and Quantitative Intersectionality Research. I love this paper, and it's not just for the content, which focuses on challenges and opportunities posed by working to enact social science research with an intersectional lens, but also because of what this paper is. It's a retrospective, a postmortem on Dr. Bowleg's prior work. And I'm struck by it because it just feels really rare to see in my field. So I'm grateful for this moment right now because I'm going to use the Scholars Lecture to do this myself and to reflect on what I've learned as an early career researcher. To reflect on my work, I first have to reflect on who I am. So I am a Black woman. I'm often in spaces where there aren't that many of us. This is a picture of me after I joined a historically Black sorority at my historically and predominantly white undergraduate institution. I am a millennial, which is how my aunt says it when she's making fun of me, but it's true. I'm technically a millennial with all of the baggage that that entails. And yes, I did have avocado toast twice this week for breakfast. I'm a math lover, and please don't exit the Zoom. I'm not gonna get too mathy today, but I do use statistics to help bring my findings to light and to help uncover what might be hidden. And I'm a psychologist, specifically a clinical psychologist. So I'm tuned in to think about the individual, the client, the single case in front of me. And of course, I'm more than those things, but this isn't that long of a talk. It turns out that that psychology piece, the clinical psychologist piece, is really strong, even when I don't think it is. But all of these other pieces that I've described are constantly fighting with that inclination to look at the individual. Being a Black woman means that I know that the things that I've experienced or that I've witnessed my family experience aren't unique, isolated occurrences. Being a millennial means that I know the shared impact of big global events like the Great Recession on wide swaths of the population. And I mean, even being a math lover, a stats lover, it means that I know that you can't stand on a single value. Constants are boring. We look for variability. And to have that, you have to have more than one case. And I don't mean to imply that all psychologists are focused only on individuals. Social psychologists like Dr. Bowleg examine environmental influences, and developmental psychologists are all about how other people, places, and things affect us over the lifespan. But in my area, in clinical psychology, we've done far less of this. And in fact, I kind of wanted to name this talk by labeling myself a bad psychologist, a la Roxane Gay's bad feminist. But I've heard that if you have to explain a joke, it probably isn't worth it, so I scrapped it. Nonetheless, I do want to use today to achieve two primary goals. First, I'm hoping to highlight the many ways that my fellow clinical psychologists and really any researchers can move beyond the individual to produce stronger work. And I'll be using the term the individual in several ways to highlight this point. And second, I just want to offer a few reflections on key lessons that I've learned along the way in my research, using specific examples from projects I've recently worked on. My plan is to walk through 3 studies, providing examples of what I mean when I say it's more than the individual, and leaving you with a reflection for each study that hopefully will resonate with folks and maybe aid trainees in your continued research journeys. So let's hop to it. The first study I want to talk about is one that I worked on a couple of years ago, focused on medical providers' PrEP prescription behaviors. That is a tongue twister. In this instance, my "it's more than the individual" refers quite literally to it being about more than just me and my ideas. My selling point in moving beyond the individual here is that by including multiple researchers with varied experiences, you can significantly improve the research process and the outcome. In this study, our research team included clinical psychologists, not just me, but another one too, a physician who specializes in working with people living with HIV, a physician assistant, and the director of a large professional organization of HIV specialists. And I'll talk about why this combination of people was so important in conducting this work. So in order to understand this study, you do have to know what PrEP is. PrEP is a shorthand for pre-exposure prophylaxis, and it's been applied to the field of HIV prevention. It's treatment as prevention, in which someone who is not living with HIV takes a medication that is used to treat HIV in order to prevent infection. Currently, there are 2 FDA-approved medications for use as PrEP. You might have seen commercials for them, or in the before times, there were ads in metro stations throughout the DC area advertising PrEP. Truvada, pictured here, was first approved in 2012 for all people at risk for HIV through sex or drug use. And more recently, Descovy is approved for people at risk for HIV infection through sex, but not approved for people assigned female at birth who are at risk from vaginal sex. When taken as prescribed, PrEP significantly reduces the risk of HIV infection. For example, daily use of Truvada, which is the recommended regimen, reduces the risk of infection from sex by 99%. And evidence suggests that the reduction in risk from injection drug use is around 74%. PrEP has certainly been a game changer in the realm of HIV prevention, but since its rollout, it hasn't been perfect. There exist disparities in access to PrEP across key demographic groups in the United States. And a recent systematic review and meta-analysis found that although overall PrEP uptake has increased over the past few years, certain groups who experience higher rates of infection, such as younger adults, people living in the southern United States, and Black people, have lower rates of PrEP use. And while rates of use are much higher for men who have sex with men, they're relatively low even for women who are at really high risk of infection, the majority of whom are Black and/or Latina. Similarly, much less research has focused on the specific PrEP uptake experiences of trans women or of people who use injection drugs. And I have to stress that each of these groups is medically indicated for PrEP use. And there are a host of factors that play into why some of these groups have less access and less knowledge around PrEP, and a lot of them are structurally based. In our specific study, we wanted to learn more about healthcare providers' PrEP prescribing behaviors. I really set myself up with a tongue twister. And we also wanted to learn how they monitor their patients who use PrEP. We knew from our previous findings and from others' work that some healthcare providers held biased attitudes about prescribing PrEP in general. Frequently, providers, particularly in the South, noted concerns that people might engage in riskier behaviors if they used PrEP. And we knew that providers differed in their willingness to prescribe PrEP to certain demographic groups, with a finding that our team and other researchers repeated that medical providers were overwhelmingly hesitant to prescribe PrEP to people who use injection drugs, even though they're included in the CDC recommendations. So in this study, we wanted to move beyond just examining attitudes about PrEP and instead focus on prescription behaviors among folks who at that time would be considered early adopters of PrEP, HIV specialists. So you can see how it was useful working with the director of one of the biggest organizations of HIV specialists, because he was a great doorbuster. He provided us access to a group of providers affiliated with that association. But having a physician assistant on the team helped us stay attuned to the importance of avoiding the all too common pitfall in this area of research of focusing exclusively on physicians' prescribing behaviors, and to instead think more inclusively about more of the providers who have prescription privileges, like nurse practitioners and PAs. And these folks are the ones with whom minoritized groups often are more likely to interact than physicians. In developing our survey, the physician on our team randomly shared that so many of her patients who identified as gay men came in, hands out, asking for PrEP prescriptions because of targeted advertising that they'd seen on apps and social media. But she frequently struggled to find openers to introduce PrEP to her patients who occupied other social identities. Because of this conversation, we added a couple of questions to our survey about who initiated the conversation about PrEP, and that ended up being our major finding. It's a very straightforward finding. This is not one of my fancy statistical models, but the finding was that providers who initiated the conversation about PrEP with their patients had more diverse caseloads of patients who used PrEP. They had higher proportions of trans folks, straight people, people who engage in sex work, people who inject drugs, than providers who relied on their patients to broach the subject first. And as straightforward as that finding was, it was also a finding that had a pretty easy recommendation tied to it. Providers shouldn't wait for their patients to ask about PrEP. And that's particularly true for groups who experience high rates of access barriers, including barriers to knowledge about PrEP in the first place. Now, this was not where we started, but I really like this finding, which is kind of strange to say, I know. But I like it more because this simple correlation has been incorporated into other work and cited by other researchers who've engaged with it in more complex and really important ways. So for example, this paper has been cited in research that examines Black women's comfort levels talking about PrEP with their healthcare providers, in work that addresses that over-reliance on self-advocacy for access to PrEP among sexual and gender minoritized folks, and in work that focuses on increasing healthcare workers, including pharmacists, knowledge of PrEP so that they can start the conversation and aid in increased uptake. And so even though it's a really straightforward, simple finding, I'm proud of it. So I'm proud that it's been incorporated into other folks' work. So like our main finding, my lesson from this study is also pretty straightforward. Listen more, collaborate more, soak in the expertise of those around you, but own your own expertise too. This study really helped me realize the value in collaboration across disciplines. Although I'd been working in a multidisciplinary team as a clinician, this study was an early opportunity for me to do that in my research. And I included both sides in this reflection to soak in the expertise of those around me, because clearly it was Dr. Brown's clinical experience that played a huge role in how this project turned out. But I also want to highlight the importance of owning your own, or in this case, my own expertise, because I could have gotten in my own way on this project. I was a postdoc, everybody else was more senior than me. and I was really hesitant to rock the boat in any way. But I knew the literature well, and I helped to get that conversation question into the final survey, even though we weren't so sure about it. So don't discount what you bring to the table too. So that's my reflection number one. And if you'd like to read this paper, I've included the citation here, and I'm happy to share my slides after this. I thank my wonderful collaborators on this project. All right, study 2. The second study I want to talk about just wrapped up this last year, and it focuses on the thing that we're all living with, the COVID-19 pandemic. Now, when I was finishing my clinical internship at the University of Washington Medical Center, I was offered a part-time position to serve as a clinician on a large NIH-funded trial on the combined effects of medication and cognitive behavioral therapy on pain self-management among people with fibromyalgia. And I was really happy about that for a few reasons. One, I was starting a postdoc that was primarily research focused, and I didn't want to completely abandon my clinical skills. And two, Seattle is expensive. Internship and postdoc pay too little, and people keep making me pay bills. So I was happy to have a side hustle to add to that. But through that experience, I also had the opportunity to collaborate with Dr. Dennis Turk, who is the person in cognitive behavioral interventions for chronic pain. And I met Dr. Kushan Patel, who's become one of my dearest collaborators. I ended up parlaying that first clinical gig into working with Kushan on a pilot study on the joint effects of exercise and cognitive behavioral therapy for community-dwelling older adults who have painful knee osteoarthritis. Osteoarthritis, or OA, is a condition in which the cartilage between bones wears down, resulting in significant pain with movement. Somewhat paradoxically and cruelly, depending on who you're talking to, one of the best treatments is physical activity. Now, this doesn't cure OA, but it helps. And as you might imagine, increasing activity for a condition associated with pain is not always met with enthusiasm. So we combined a pre-existing, empirically supported, group-based exercise program that took place in community centers with the group-based cognitive behavioral program that we created to promote pain self-management and physical activity. We piloted the intervention, and we got promising results that showed the benefit of this combination over exercise and exercise plus a health education control group. On outcomes that were measured through actigraphy, like Fitbits, standard assessments of activity, like the 6-minute walk test, and on self-reported measures, the treatment group outperformed that health education plus exercise control group at the end of the 4-month intervention. We then worked on a larger grant to scale the intervention and ultimately try to enroll over 200 older adults, which was eventually funded by the National Institute on Aging. I flew back to Seattle, I trained the new psychologist on the protocol, and then the study started enrolling people in October 2019. And everything was great. Until it wasn't. You all know what this is. So in thinking about moving beyond the individual here, my pitch lies in the importance of recognizing larger forces that play on us all the time. In this case, it's a really concentrated and specific force, COVID-19. So in the middle of this intervention, our group-based study of older adults in Seattle, one of the first places where COVID landed in the US, was shut down immediately, like day one. And it was stressful for me as a collaborator and a consultant. I can't imagine how stressful it was for my friend Kushan, the PI of the study. But nonetheless, we met to figure out if there was anything that we could do And we had a conversation about how the COVID-19 narrative around frail, vulnerable, older adults just didn't seem to map onto what our experiences were with this vibrant and active group. Recognizing that the train had kind of already left the station, we decided to switch gears and ask our participants in a systematic way about the impact of the stay-at-home orders on their overall functioning. We gathered the sample of enrolled participants, which at that time was just about 40 people, and everybody except one person agreed to participate in this sub-study. We repeated quantitative measures of mood, functioning, and health behaviors that we had gathered when folks first enrolled in the study to see if there were changes that occurred that coincided with the pandemic. We added a few more quantitative measures of perceived risk and worry about COVID-19 to get at trends and reactions to the pandemic. And then we conducted semi-structured qualitative interviews over the phone with participants. And it's important to note that these data were collected early in the pandemic, so in March and April of last year. On the quantitative side of things, we found that this sample of older adults reported significant increases in anxiety symptoms, but decreases in fatigue over the time from when they joined the study to the beginning of the pandemic. We also found the biggest change was in their participation in social roles. That change was nearly a full standard deviation decrease and reflected clinical levels of decline. And this is particularly troubling given the strong relationships between social support, loneliness, isolation, and health among older adults. We didn't find significant changes on other domains like depression, sleep problems, or general functioning. And with regard to those perceived risk questions, the degree of worry about infection was really a mixed bag in this sample. Half of the folks reported that they weren't really worried at all, and the other half said they were extremely worried. But still, given that they were all in the age with the highest bracket of their age bracket with the highest level of risk, they all did endorse feeling susceptible to the virus. Now, remember, keep in mind, this study was done at the start of the pandemic last year. But when asked about their confidence in being able to prevent the spread of COVID and prevent infections, our sample was the most confident in themselves, good for self-esteem, and the least confident in the US federal government, which with the benefit of, or maybe the detriment of a whole year's worth of knowledge about the pandemic, might have been a fair assessment here. In our qualitative interviews, we identified 5 major themes that emerged. First, older adults talked a lot about the disruption of their social activities and daily routines. And there was frequent discussion of the loss of activities specifically related to grandkids and what it might mean to miss out on the limited time that they had with their grandchildren. One of the really interesting social losses captured was the loss of spontaneous conversations. So not having the chance to speak with the barista or the person that you pass on your walk or the person delivering mail. And this particular loss, these kind of spontaneous conversations that erupt, were felt especially acutely for folks who didn't have a large social network. Older adults also discussed the emotional toll of COVID-19 overall. Consistent with those quantitative findings, they highlighted the increase in anxiety, and a portion of them attributed that to a sort of compulsive tendency to consume media about the pandemic, which I'm sure many of us can relate to. They also noted the hypervigilance of focusing in on their physical state. So is that sniffle a cold, an allergy, or COVID? And they talked about the way that that's particularly heightened that fear for older people. The third theme focused on the physical impact of COVID. All of these folks have osteoarthritis, and engaging in graded physical activity can help that. But in losing the study, they lost their 3 times a week group-based exercise program. And some participants were able to find new ways to safely exercise, but many just talked about the challenges of finding the motivation to be active when they were stuck at home by themselves. But the findings weren't all negative. We didn't prompt for positives, but several folks identified positive changes that have come about for them as a result of the pandemic. They highlighted having the time to finally finish things that they'd been putting off, and opportunities to rekindle old hobbies and relationships. And this was often supported by their use of technology. Our final theme focused on older adults' perceptions of how the pandemic was being handled, especially all that attention on older adults as extra vulnerable, or in some cases, the spotlight on them as being the reason we can't just proceed as usual. You may remember that around that time, there was a lot of public callous talk about whether grandma would mind being sacrificed for the greater good. In general, our sample of older adults were supportive of the protection mandates that were put in place. They were adhering to them, and they had a lot of choice words about the federal response. So choice, in fact, that we had to do a lot of sifting to find quotes that we could pull for the article. So through this study, we were really pleased because we were able to document the experiences of a segment of the older adult population that is the biggest segment, the most representative being community dwelling older adults, but wasn't getting a lot of attention in the context of the pandemic. And my greatest lesson from this particular study was the value of being flexible and adapting to changes. This was an extra mini study that we tried to do in the context of a major disruption of everything. This project happened at a terrible time. The pandemic was new. I just bought and moved into a new house that we couldn't furnish thanks to lockdown and delivery delays. And my father had unexpectedly died. Things were not great. But this project was interesting. It made me feel like I could devote my chaotic energy to something. And it was really a joy to work with or to work on. I learned more about qualitative methods. I got to strengthen my relationship with my collaborators, and I could do it all from my home. Now, I do not mean to imply that if things are extra rough, that you should go ahead and add a new project. Absolutely not. You should take breaks, stop when you need to. But if you hit a roadblock, it might be good to just sit back, get creative, and see if you can approach it from a different angle. Because like our participants said, there can be unexpected positives, even in the middle of negative situations. So if you'd like to read this paper, I've added it here. And again, I'm just so grateful to my wonderful collaborators on this project. And I really look forward to being able to return to the original intent of this study and go back to enrolling participants. All right, the last project I want to talk about is one that I just finished working on, like this afternoon. And here, when I'm referring to moving beyond the individual, I'm talking about moving beyond the individual piece of data and paying attention to patterns. So my pitch for why this is good, a good use of moving from the individual, is that by attending to these patterns that emerge, you just might unlock a new line of inquiry. So let's talk about this project. It began, as many things do, by complaining over text message. So the conversation went a little something like this. A text from me. Feeling very annoyed. Just reviewed another paper that claims that Black people have worse health because they're, get this, Black. My friend Adam, also a clinical psychologist and an adolescent suicide researcher, replied, ugh, I just reviewed another paper that says the same thing about suicidality in LGBTQIA+ kids. Me. This keeps happening. I'm over it. Adam. Maybe we should write about it. Me. I started to type, then I stopped, and I left him on red for a while. And I really was intrigued by the idea because by this point, we'd had several conversations about this same thing happening over and over again. But I was also nervous because what would it mean for me as a Black, early career, pre-tenure person to write a paper essentially yelling at people in my field to stop it? But I did want them to stop it because what we were describing in that text thread was this depiction that's seen over and over again. Whether folks intend for it or don't intend for it to be this way, the message often shares that a person's minoritized status is the reason that they have worse outcomes. However, this fails to recognize the roles of unique experiences of minoritized folks that set this path into motion. It's not so much being Black that's bad, it's the racism. And this was particularly troubling because we have several frameworks and models, some of which were developed by psychologists that provide other constructs that we should consider in exploring why and how minoritized folks experience worse outcomes in some domains. So Adam and I decided to pursue the paper. We started it before the pandemic struck, and we were chipping away at it. And then last summer, with George Floyd, Breonna Taylor, Tony McDade, and others happened, and we moved to push forward on it. We decided to systematically review how the top 5 empirical journals in our field of clinical psychology wrote about mental health among minoritized groups. And those journals were the Journal of Abnormal Psychology, Psychological Medicine, Clinical Psychological Science, Depression and Anxiety, and the Journal of Consulting in Clinical Psychology. We called on several frameworks that theorize about mental health disparities among minoritized groups. These frameworks have different terminology, and they're often developed based on particular minoritized groups, but they share an emphasis on examining structural factors outside of the individual and on exploring the unique internal stressors faced by minoritized folks. So we included the multicultural stress model, the biopsychosocial model of racism, the multidimensional conceptualization of racism-related stress, the minority stress model, and the gender minority stress model, which is an extension of Myers to focus specifically on the experiences of trans and gender nonconforming folks. Now, of these, the minority stress model is the most widely cited one. It has over 9,000 citations. But I want to take this moment to recognize, which Meyer does, that the minority stress model was built using these other frameworks, like Clark's, which is also widely cited. David R. Williams is a co-author on Clark's biopsychosocial model paper. And if you're familiar with David R. Williams's work, you can understand the reach of this paper. But even as widely cited as this Clark paper is, it has 1/3 of the total number of citations that Myers' minority stress model has. So we went about our search by following a couple of steps. First, we searched for the actual names of the models in each of the 5 target journals. Second, we did a backward search where we looked at articles that cited the papers that introduced the models, and we searched for any that were published in our 5 journals of interest. And the goal here was to kind of capture articles that perhaps didn't use the model's name, but were still inspired by or influenced by the models that we included. And then we expanded our search terms to capture a wider array of minoritized populations in terminology specific to studying them. Honestly, we expanded the search in this way to get more articles. The field wasn't very strong based on those first two steps. And lastly, as a bit of a bonus, we examined the makeup of each journal's editorial board. We specifically found every member on the board and identified their primary and secondary research areas. We were looking for whether they noted a research focus on minority health. The idea behind that being that given the gatekeeping function of editorial boards, perhaps those boards with members who conduct research on minoritized populations would be more likely to publish work that focuses on these populations. So what did we find? Let's see. After doing all of this searching, we had a final sample of 61 articles across all 5 journals from the beginning of time. Now, I'm editorializing a bit, but that's not a lot in the history of these journals. Because, for example, the Journal of Abnormal Psychology has been in publication for over 110 years. The articles that we pulled had a much stronger emphasis on LGBTQIA+ samples than on other minoritized groups. And we noticed an increase in the rate of papers published that focused on minoritized groups over time. Over half of that 61 articles were published since 2015, and 11 were published in 2020 alone, which is an encouraging trend. But still, they almost all focused on Meyer's minority stress model. The discussion of race, ethnicity, or other categories is extremely underrepresented in these top 5 journals. Now, nearly all of the included articles assessed mechanisms that are unique to minoritized individuals that are hypothesized to lead to the increased rates of mental and physical health problems that we see. 49% of our included articles measured an external mechanism that's unique to minoritized groups, like race-based discrimination or homophobic encounters. A somewhat smaller proportion included an internal mechanism unique to minoritized people. So for example, internalized homonegativity or internalized racism or expectations of rejection based on minority status. But only a quarter of them included both external and internal mechanisms. With regard to our bonus of examining editorial board makeup, only 7% of the 400 unique individuals across these 5 editorial boards had an obvious primary or secondary focus on mental health disparities in minoritized populations. And I do emphasize unique individuals because there was considerable repetition on these boards. There were about, I want to say 50 repeats across these 5 boards, which is another issue. Now, of course, this review of editorial board members' research programs was based on our own review, and people's research programs certainly change over time, but it was still stark to see. Now, 60% of the articles in our review were published in JCCP, and that journal is the only one that had an editor-in-chief who has a primary or secondary research focus on minoritized populations. That journal also has the greatest number of other editorial board members with such a research focus. And that further emphasizes our point about the gatekeeping function of these boards. So in doing this work, we highlighted and quantified, which psychologists love to do, a few pitfalls around limited measurement of external factors that affect minoritized groups. That only half of the studies considered structural factors or discrimination experiences as a problem. We also noted the failure of many of these studies to incorporate universal stressors. Part of what's particularly insidious about minority stress is that it's on top of the kind of stressors that we all face as being people. And of course, we discussed the lack of consideration or attention to intersections of marginalization. We end the paper by providing some recommendations for the field based on what we found, and hopefully using our results grounded in cold, hard numbers to support other people's calls for these kinds of changes in our field. This has been a really challenging paper to work on, especially in the midst of everything else that's been going on in the world. And it certainly has pushed me out of my comfort zone a few times. But it's also been really rewarding. And so the lesson that I've taken from this particular study is just a reminder that I and you shouldn't be afraid to use our voices. I think that the paper that we've ultimately crafted is going to be a good contribution for my field, and I'm looking forward to seeing it in print. The secondary lesson or reflection that I have here is just to remember to cultivate real friendships with at least one colleague with whom you can whine about it. I'm going to trademark that, personally and professionally. I'm really lucky to have multiple people in my life who fit this bill, and who knows, sometimes even can get a paper out of it. Speaking of which, if you'd like to read this one, it will be in print soon because we just finished the final revision today. And I am especially grateful to Adam and to the awesome research assistants that we had in his lab and in my lab that did a lot of compiling search results to get this done. So I know I've covered a lot, but I'm hoping that I've sold you on the merits of moving beyond the individual in your research and in all of the ways that the individual might show up. I also hope that, especially for undergrads and grad students embarking on their research careers, that you'll find value in the lessons that I've learned along the way. I'm really excited to take these points and reflections and apply them to my next project, which focuses on the pain treatment experiences of women living with HIV and chronic pain. I'm really looking forward to merging these two areas of interest, HIV and chronic pain, and with a population whose pain often gets overlooked. I'm confident that the lessons that I've learned thus far are going to help me in this project, and I'm sure I'll learn new lessons as I kind of continue in that. So thank you so much for your time and attention. And I just have a list here of other folks to thank, because I'm so lucky to have a strong, supportive network of research team members, colleagues, friends, family who champion me, too many to name individually, and many of whom are on this video call, which is kind of overwhelming. So thank you again. And I think we have a few minutes for questions if I didn't talk too